right.
I thought I'd be in a more regular classroom, just for
Yes,
fun.
I enjoy it. Yeah.
I know. Some of us are still old school, man. I tell you. Or it was just my grandkids going off to grade 1 in kindergarten. And, anyway, I felt like I had to support them with a background that was kind of common.
Craig, I know what you're talking about. My kids are in kindergarten and grade 1 right now, so it's
I know.
Tough. It's good to see you.
Oh, okay, just one more minute and we'll get started then. Okay, so it's 5:04, so we'll get started and we'll have people join us when they can. We did have a high number of people registered for today's session, so it's pretty exciting. My name is Sunil Varghese. I'm an infectious disease doctor at the Queensway Carleton Hospital, and I also happen to co-chair the Regional Acute Inpatient Medicine Group. And with the onset of COVID, our group has been putting on a number of webinars in cooperation with the Eastern Ontario Academic Health Sciences Network, predominantly around COVID-related issues. And we're pretty excited that this is our first webinar that is non-COVID, but as a consequence of COVID, has become really paramount. So I'd like to welcome you to our acute care webinar series, COVID-19 Clinical Updates for Physicians. And today, it's a fireside chat regarding the role of virtual care in the delivery of care in our community. And traditionally, virtual care is pretty much known as a consultant sits in an office, a patient sits somewhere else, and they communicate either by phone or OTN or some other video conferencing platform. But what I'd like today's discussion to focus around is a little bit about how we can take that to the next level in terms of improving care in the community, whether it be monitoring patients in the community, inpatient delivery of care, and then the collaboration of care amongst the different groups. And towards that aim, I'm very excited to present two speakers who have started processes and well-developed processes regarding those issues. So what I'm kind of hoping for, not what I'm hoping for, what I know what we're going to do is we're going to talk about these issues, and then we're going to have a bit of a chat amongst the presenters and all of you out there today. So our first presenter is Dr. Jonathan Fitzsimmons. He's the clinical coordinator at the Renfrew County Virtual Triage and Assessment Center and the chief of medicine at Arnprior Regional Health. He's one of the physicians who spearheaded this, the Renfrew County Virtual Triage and Assessment Center, and which is a program that helps patients who are either with or without or cannot reach their family physician to get in touch with a family physician or a nurse practitioner and set up an appointment for COVID assessment. These appointments take place over the phone or video so that the patient does not need to leave their homes. Should they require an in-person visit, people with the necessary expertise are dispatched, and early data has showed that 74% of the patients assessed by this program would otherwise likely have visited an emergency department or called 911 to do so. Our second presenter, is Dr. Jerry Maniati. He was appointed Vice President of Education for the Ottawa Hospital back in 2017, and he's an assistant professor at the University of Ottawa. Dr. Maniati moved from Toronto, where he was a community-based clinician educator and the inaugural Chief of Medical Education, Research and Scholarship and Academic Director of the Medical Education Teaching Clinical Site at St. Joseph's Health Center. He previously served as an Assistant Director of Researchers at the Wilson Center, Chair of the Faculty Council Education Committee, and an Assistant Professor of Medicine at the University of Toronto. He has long-standing involvement in the residency education program and has served at the Executive Committee as the President of the Canadian Association of Interns and Residents, and more recently with the Royal College of Physicians and Surgeons in association with its conferences, various committees, and a member of the accreditation survey teams. Dr. Maniati has also done some international educational activities and leadership. He's a member of the Royal College of Physicians and Surgeons of Canada, CanMed's Academy of Medical Educators, and he was appointed by the college as an Associate Regional Director for Kuwait. As a researcher, Dr. Maniati is currently working in two main areas, and this may have updated, exploring the intended and unintended effects of globalization and medical education systems, including accreditation, assessment, governance, curriculum, and health human resources planning, and creating novel models of medical education and research scholarship. So our plan going forward today is first Dr. Fitzsimmons is going to take some time to overview his program. Then we'll turn it over to Dr. Maniati, and then we're going to do a bit of a fireside chat. And on that note, I encourage all of you out there to participate. So if you have any questions, there is a chat function on your Teams. You can just show the conversation. It looks like a little comments icon, and you can include a question in there. Or if you'd rather, you can use the raise hand function, which I'm doing right now. And I will see that, and then I will call on you for your questions. Final housekeeping tips, please, is if you're not speaking, if you could put yourself on mute, and if you could just close your camera if you're not speaking as well. So with that, I turn it over to Dr. Fitzsimmons. Thank you very much.
Thanks, Sunil. Welcome everyone, and thanks for the opportunity to talk to you all this evening. So as Sunil said, we had a unique opportunity in Renfrew County to deal with some of the unique challenges that we face in our area. And this came about when the drive in early March for COVID assessment centres became very clear. And we realised very quickly that Renfrew County, being the largest geographic county in Ontario, spread over 7,500 square kilometres for a population just over 100,000, was not going to fall neatly into the box of a large Brewer Park style assessment centre where large numbers of people, huge numbers of people could simply just go to a fixed location site. So we knew that our geography was going to pose a real problem, but we also knew that there's an added layer of problem in Renfrew County, and that about 23,000 residents do not have a regular family physician or primary care provider, and there are no walk-in centres in Renfrew County. So it means that for a huge chunk of the population, essentially close to a quarter of the population, their only way of accessing any form of healthcare was or is through an emergency department. And so, of course, when we started talking about giving access to people for COVID-19 testing, when we started putting the request for people to refrain from attending emergency departments unless they have a genuine emergency, to not congregate, not to attend doctors' clinics if they didn't really need to, that was all well and good, providing there was an alternative. And so we started having discussions about, well, how can we provide that alternative? We do not want people to suffer in silence at home, but we want to protect our emergency departments, our 911 paramedics, and our doctors' offices. And so we developed the idea of having a virtual triage and assessment centre, something that would be accessible to every member of the county, every resident of the county, but would help us achieve those aims of protecting the hospitals and doctors' offices and healthcare staff, whilst also giving people that option. So what do I do if I do have an urgent healthcare option? And we came up with a tagline that the first thing you do is call your family doctor. But if you don't have a family doctor or you can't access your family doctor, you call us, you call VTAC. And it triggered what I would, for me personally, has been the most incredible amount of collaboration and cooperation between different healthcare providers that I've ever experienced over a time scale that was just sort of unheard of in healthcare. So essentially over 12 days, a 12-day period, we went from a conversation about what would a virtual triage and assessment centre look like, through putting in a proposal, getting Ministry of Health approval, and going live to the public, all in 12 days. And one thing we realised was that we would need to integrate really closely primary care, hospitals, public health, and importantly, the community paramedic service. And we developed an idea that all of our COVID testing would be done by the community paramedics, but all of the assessment would be done via virtual means, telephone, video upgrades available by family physicians, and a few nurse practitioners. But by having integration with everything from the emergency departments, hospital staff, mental health providers, palliative care providers, you name it, long-term care, social care, community pharmacy, they all had a seat at this table we put together for VTAC. That if we fully integrated, we would truly be able to offer that that safety net to every member of the population, that they could get an assessment, they could get a COVID test if it was needed, and they wouldn't need to go to an emergency department for things that were not emergencies. I'm going to share a slide with you, which I'm going to share a couple of slides. Firstly, to show the sort of Sunil, can you just confirm that you can see my slide there, because my screen just changed. I don't know if you can all see it.
Yeah, we can see it. Thank you.
So firstly, to show the complexity of what we did, if you want to look at it that way, and by complexity, I just mean that it involved an awful lot of different people, driven by primary care. So both as family physicians and the administrators of our family health teams and family health centres across the county, but closely connected with all of those other organisations that I just mentioned. And by having those different organisations closely linked, we were actually able to offer a very simple message to the public. And we could even narrow it down to a simple traffic light system. So yes, you know, the first port of call is call your family doctor. But if you can't do that, you don't have a family doc or you can't access them, here's a free phone number that you can call, and you will be connected to a family physician. And that's what we did. So, you know, an integrated sort of approach with an electronic medical record system, so that patients call and then they get registered onto an EMR. And so the family doctor working from home, or working from the clinic, or working from anywhere where they can remotely access the EMR schedule, can then call the patient. And that's where I say we had the traffic light approach. Many, perhaps over 90% originally, and well over 90% now, many of the sort of the assessments that they do are just dealt with over the phone by the physician. There are times when we need sort of additional support, and that's where the link with the community paramedics really kicked in. So although that assessment is predominantly done virtually initially, there is still that sort of in-person option available. Paramedics could go out to the patient's home. They could do COVID tests, they can do vital signs, they can do many of the assessments that community paramedics do so well and have been doing well before COVID. But there was that instant link between paramedic and family physician to support the management process at that point. And of course, there is always the option to still revert to the 911 call or present to the emergency department. But when you look back to what our initial goal was, to protect the emergency departments for just genuine emergencies, we were able to take so many of the cases where people would have turned up to the emerge because they had no other option, and deal with them over the phone, over a video, or occasionally with a paramedic providing a home visit to support that management process. And so for the patient, it really was a very simple flow. They call, they speak to a medical receptionist, they take some registration details, and then they get given an appointment time, typically within a couple of hours, often sort of shorter than that. And then a family physician calls them at home. They deal with it over the phone. They may be sort of upgraded to a video appointment if needed. They can escalate the care, and that's where all of that complex slide that I referred to, but was really just linking all of our existing healthcare services within the county to add on other layers of care if needed. And then there's also that option that if this needs to change to a 911 paramedic call and transfer to emergency care, then that's still available. The one other layer that I haven't sort of I haven't mentioned is the sort of in between dealing with it today and taking it to an emergency department. So our paramedics do have the remote monitoring equipment, and so we do have a system embedded within the VTAC where paramedics can leave behind digital remote monitoring equipment. Patients take their own vital signs on a predetermined basis, and we have a physician who every day is liaising with the paramedic desk and remotely monitoring those signs with different sort of criteria set for when care would need to be escalated. So we feel like that layered approach from the simple telephone call all the way through to digital remote monitoring with a check-in on a daily basis has really embraced the sort of spirit of virtual care, particularly in the context of the COVID pandemic. And it absolutely fulfilled our aim to protect the emergency department and the 911 paramedics. And the sort of the added bonus of that was it also helped us protect our PPE supply, particularly early on when that was so problematic. With this approach, you don't need every single family physician office across the county fully prepared with a PPE supply. Actually, the vast majority of it was able to go to our paramedics because they are the ones doing the COVID testing and the in-person assessments. So that's that sort of concludes what I wanted to say initially about how and why we were set up and what we're able to offer. So now perhaps I'll hand back to you now, and then at an appropriate time, I'm happy to take any questions.
Yeah, there's a couple questions. Dr. Campbell has a question there that I think, so it doesn't get lost later on. Yep. Is what were the criteria used to determine a call versus a video-based assessment?
So two criteria, I would say. One is it clinically necessary? And two, is it logistically, technologically possible? So does the family physician feel that, look, you're describing a rash to me in words. Is there any chance we can turn a video camera on so I can have a look at this? That might be the clinical criteria. And then, of course, the logistic criteria is, do you have a webcam? Or are you sort of technologically able to do this? So we use the Doxy and .me video conferencing sort of system, which is a medical grade telemedicine sort of platform, and it really is as quick as the physician just clicks one button, that generates a link which you can text message or email to the patient, and then they click on the link and it opens up a video conference like this. For some people that's super simple and it literally takes 30 seconds. For other people it's just not possible, and so you just have to move on.
Great, thanks. One of the thank you for that and the program overview. One of the things that seemed very interesting about it, how this could be scaled up to involving inpatient care or emergency room assessments. Do you guys have some experience on that? So
one thing we found, particularly for the emergency departments, and two chiefs of emergency of the 5 hospitals in Renfrew County sit on the VTAC leadership table. is that we were able to set up a communication link to help not just prevent transfers to the emergency department, but for the people that are in the emergency department, prevent them having to admit somebody because there was no care available at home. So we had a number of cases where an emerge doc would call VTAC and say, look, I've got a patient that, you know, has had some worsening of their heart failure or their COPD, you know, or other chronic diseases. I'm struggling to get some community services, but I don't really want to admit the patient, but I don't really want to just send them home. Is there any chance that we can arrange for someone to check in on them tomorrow? Or so we became a sort of assistant backup, if you like, to the emergency department, that because many of our patients don't have a family physician. So when you're in emerge and you say you need to follow up with your family doc, and the patient says, I don't have a family doc, you know, does that then trigger you thinking, I'm going to have to admit this patient now? And so we were able to provide a little bit of community backup to the emergency physicians. And you can follow that through to the inpatient unit as well when you're planning discharge. Same deal, you know, if you know that patient does not have a family physician, is this a factor that's delaying your discharge because you're nervous about sending them home? Well, you know, the VTAC service is available. We can set up a community paramedic home visit the next day, and that paramedic will be able to link directly to the VTAC physician if there's a problem, or we could set up home monitoring. So it's another layer of community care that we've been able to offer to our emergency and inpatient colleagues.
That's great. Thank you. Thank you. Do we have any other immediate questions for Dr. Fitzsimmons? And if not, I will turn the floor over to Dr. Maniati to talk about how virtual care can be used to facilitate care in hospital.
Well, thanks very much, Sunil, and thank you for the invitation to participate with the conversation this evening. And it's good to sort of follow off from Jonathan's presentation as well, where he was talking about sort of that outpatient primary care kind of setting, and yet there's potential for interface with the ED. So my sort of take on this presentation is to focus in on the inpatient experience and the context that we find on that side. I suppose just to set the context as well, for many who are on this call, you would know that at least at the Ottawa Hospital, as well as other Atlas Alliance partners in the region, we've been using the EPIC Health Information System platform for a little over a year now. And to be honest, I think this has been part of the reason why some of these things might be even possible that we're going to be presenting this evening. So I'm just going to go to the next slide, and first of all to acknowledge Dr. Glenn Geiger, and Glenn and myself have been sort of bouncing ideas back and forth over the last few months, and we're starting to see where things are heading. Glenn is our TOH Chief Medical Information Officer, and he's also a general internist like myself at the Ottawa Hospital. So where are we right now? Well, definitely changing clinical care context, and the pandemic has really forced a lot of massive change. And we're still in the midst of things and still sort of waiting to see what subsequent waves are going to be like. But it's resulted in a lot of reacting immediately and doing some immediate sort of decision making. It's forced a lot of pivoting kind of activities where people are needing to respond to other needs with different type of resources and different constraints. And then we start getting into this, well, is this our new normal? And maybe should we be thinking about new opportunities and new ways of thinking, this sort of reimagining sort of phase? And while all of us are still feeling like in some ways we're still in the react and pivoting, there is a light at the end of the tunnel, and it's not a train that's heading towards us, but there will be a time in which we will be entering a new type of reality, and there may be some opportunity to prepare our system to manage that. So the reimagine sort of take, well, definitely we've had some constraints and changes even within our hospital. Normally our hospitals are jammed with lots of patients, but also people who work there. And we've had to take into account physical distancing constraints as well, our hand hygiene, disinfection, but also monitoring for symptoms and screening, and even some basic sort of practical things like how many people are in lunchrooms and in the clinical workspaces. So with these type of things in the back of our mind, we've sort of had to think, is the current way that we were providing care, is that sustainable? Is that even possible? Or are there other ways that we should be looking towards? And so there's this opportunity to look at virtual rounding and consultation. And once again, in the era of paper charts and binders that used to exist prior to June 1st, 2019, at the Ottawa Hospital, this probably wasn't possible to the extent that it is right now, because our platform has changed. So you think about what we used to do, especially on the left-hand side, our bedside care, our rounds, our conference room team rounding, and even our teaching, all of it was really dependent upon being in person. And quite radically, in some cases, it felt like it was happening overnight or within a span of a few days or weeks. We were radically shifting over to the right. Our bedside care, we were starting to implement monitors that would be able to track, whether through cameras or other devices, to keep an eye centrally what was going on with patients at unit station desks. The concept of bedside rounding and use of a feature within the Epic platform called Virtual Consult would permit the consultation of patients. The clinician could stay in an office, perhaps at a different campus or even a different location, to actually accomplish what they would normally have done in the in-person kind of setting. The concept of virtual rounding, where teams, where patients are scattered throughout an organization, and the team members may themselves also be scattered, can come together at certain time points to have those interprofessional or team conversations to aid in patient care, discharge planning, and other interprofessional type of measures that need to be taken to help further the patient's care. The last sort of point talks about the Microsoft Teams. When this is a good example where historically we were all pretty reliant upon being in the same room, same place, as we quote unquote would say, bum and seat experience for our education and teaching. And now we're leveraging resources and platforms such as Microsoft Teams to accomplish some of those things. So I think all of these measures, when we talk about sort of concept of virtual rounding and virtual consults, has to be supported by two key pieces. One being the clinical workflow will have to be adjusted or changed to accommodate this. And secondly is the infrastructure, and there are two sort of facets to that, one being digital and second being physical. And I'll just take a couple moments just to describe a couple of those changes. So for example, with the clinical workflow, the old way of doing it was face-to-face, whether it was consultation or rounding, and now you have to create a mechanism in which the virtual version of consultation or virtual rounding can occur. It's a change in mindset. It's a change in how we've trained most of us on what our expectations are. It's also a change in expectation for the patients and their family as well. And so there's a lot of things that have to be done, and as much of this is process and SOPs and sort of structure, there's also a culture aspect to this as well. Then from an infrastructure point of view, there, as I mentioned, there's digital aspects, but there's also the physical aspects as well. And from the digital perspective, most of this is just embedded within the platform that an organization has. In our case, Epic has certain functionalities that we can turn on and enable the capability of supporting this. Then on the physical side, you have to think, okay, well, I guess we can't just, we could probably just take an iPad and stick it on a stand and roll it into the room. That's one way of doing it, but in rooms in which patients are not capable of doing that because of their care needs, perhaps there's microphones and cameras that are required. There's potential for real-time monitoring that is required as well. So these are infrastructure that you need to install, or to certainly make sure that your Wi-Fi system is strong enough that they can support the extra additional devices that are drawing from the bandwidth. But we also have the potential of saying, well, what about the home kind of support piece? What if patients, and Jonathan was alluding to some of this, what if we want to send patients home? What if we need to connect up? Is there other kind of things that we can do to support that? Both for the clinician who might be at home, but also the patient who might be discharged home. There's different ways of supporting that. And then some physical stuff with regards to our spaces. There's just not enough space in most unit stations to accommodate just the existing workforce from a physical distancing. And so maybe there's purpose of either having stations that are mobile. We have workstation wheels, which may help in our setting, but there's also the possibility of setting up workstation type of hubs throughout the organization that would allow for people to have these consultation rounding opportunities with patients, but also team members as well. So just to give a couple of ideas of some of the tools that we're talking about. For example, in the inpatient side, the concept of virtual rounding, where you've got the data that's coming in from monitors and devices. It feeds into the Epic system, and then it allows the clinicians that are tapped in, whether it's at a desktop type of situation, or it's on their mobile devices, iPads or tablets or their phones, that they can access that information together to help make decisions with patients, and engaging those patients, whether it's through iPads or other two-way communication type of devices, is certainly possible. So this would be an example of one of our windows in the Epic system. And for those who know the Epic system, this will look familiar. And I'll just point out for some of you may not have seen these two sort of tabs on the bottom here, video consult and rounding. These are the two buttons that essentially enable the functionality to be actually activated right now. And once you've pressed on that button, you actually just simply click to connect to video, which then pushes you actually to an enterprise grade Zoom. So this is Zoom for essentially healthcare with all the appropriate privacy and ITIS security features. So this is not your free Zoom that somebody can Zoom bomb you, is what we understand. So there's security, and it's within the Epic platform. And so once you've done that, you open, and you get, well, in this case, Dr. Geiger speaking to you. But it's as simple as that, and it allows the rapidity of getting these kind of connections. It's intended to be user-friendly. And now we need to start thinking, is this a possibility to help us enable moving into spaces and areas that we haven't otherwise thought of. So in terms of sort of questions or things to sort of think about, I always pose these type of questions, is this actually a feasible kind of idea, or is this kind of pie in the sky? What are some of the constraints or barriers that might exist? What are some of the concerns that people have, whether it's from a patient perspective, family perspective, staff perspective? What are some of the concerns? And are there other alternatives that we can consider, once again, considering the constraints that we're facing? So, Sunil, I'm going to pause right there. And
that's great. Thank you, Jerry.
No problem.
Excited, and I'm particularly happy that you showed us what EPIC looks like, because I've never seen it. The screen.
There you go. Thought I would do a bit of a show and tell on that too.
It's great. I put a little comment in the chat. If anybody does have any questions that they want to add in the chat, please do. Or like I said before, you can raise your hand with the little hand icon. There. All right. John's back too. So I do have a couple questions, and maybe I'll start the conversation off. Is where do each of you see this going in the future? I mean, to me, there's so many exciting potentials on both of what you've described and what you guys have explained to us. Where do each of you see the future? A year, 2 years down the road, maybe even longer? Jonathan, maybe I'll start with you.
Sure. So one thing I've been very open and upfront about and very conscious of is that VTAC is not a substitute for primary care. We do not provide full spectrum primary care. We provide acute episodic care. So it isn't really a platform for health promotion and disease prevention. It isn't a great platform for chronic disease management. And they're two of the three pillars of primary care. So it's fantastic for acute episodic care, but it's not really doing 2/3 of what I as a family physician do every day in my office. Mm-hmm. So what we've been looking at and the evolution of VTAC, if you like, is how do we take the good points, the benefits, and what we've learned from what VTAC can do, and I should point out what patients are clearly super happy with. You know, the CMA study sent out in May, I think it was, showed that over 90% of patients are satisfied or very satisfied with virtual care. How can we take that and use it to address or start to address this real disparity in access to primary care, particularly in a place like Renfrew County where there are no walk-in centres? And so our hope is to develop and to pilot a virtual family health team, so from VTAC to VFit. So that's to partner with a family health centre in Renfrew County that has existing funding to hire new physicians. If 2 new physicians walked into the Petawawa Family Health Centre tomorrow, their executive director would hire them on the spot and has funding in place to do that. But we can't recruit physicians. We haven't been able to recruit physicians for years. So why not have the ability for a patient to roster to a family physician, to see their family physician as you are all seeing me now, and if they need the physical component, whether that's an examination or a procedure, we utilize allied health professionals like we've done with community paramedics. But in a family health center, you have nurse practitioners and nursing staff and, you know, the whole range of allied health. In the local hospitals, you have surgeons that do minor procedures clinics. You have sports meds physicians that do joint injections. So bring those sort of additional components together, but have a named family physician who provides all aspects of primary care, albeit via virtual or remote means. And the defense to the obvious question that people sort of, or the obvious sort of, but, you know, that people sort of, it's not the same as being, you know, in your office. And I get that, you know, I have a beautiful office in a big brand new clinic, and my patients all live, you know, in town and can come and see me. And that's the gold standard. It's fantastic. Don't compare what I'm suggesting to that. Compare what I'm suggesting to what 23,000 people in Renfrew County have. Your only access to healthcare is through the emergency department. So when you look at it from the existing shortfall, a remote family physician, but your own named family physician supported by allied health in your community is many, many times better than what you currently have. I accept it's not quite the gold standard that I'm fortunate enough to practice in, a family health team in a small town where people can access me and my multidisciplinary team. But I'm not claiming it to be that. I just think that we can move to full spectrum primary care utilizing some of the things we've learned from VTAC, which offers acute episodic care.
Wow. Yeah, that would be amazing. Jerry, where do you think this would go?
So it's interesting, and I actually really like Declan's comment that he's got in the chat there.
Yes.
And actually, that's exactly where I'm thinking this is potentially could go. And I'm not sort of, thinking far in the future. I think this is possible to be done sooner rather than later. And it goes on to the fact that at least even right now, we do have hospitals that are in Eastern Ontario that are already on the Epic platform, at least within and connected with TOH. And so at least within those settings, there's the possibility already that a doc at Barry's Bay can log into Epic, pull up their patient, call me and say, Jerry, can you take a look at this patient that's currently in our either ED or inpatient unit? I'd like to run this by you. Historically, what would have happened is you're getting a verbal over the phone, and picture's worth 1,000 words, as they say. And so there's still a limitation of communicating the acuity of or what's going on with the patient. And so the default is, well, okay, fine, send them, and we'll see what's going on. And I think having the fact that you have access to data that we just didn't have, the Epic system pools, the latest labs, the latest vital signs, the most recent notes are there in a contemporaneous way. But what if you superimposed additional technologies into that? Now, maybe this is a little bit more futuristic, but have a robot wheel into the patient's room that actually has camera and has has sort of an interface capability that a person could actually sit there and watch what's going on. Now, this is not the big futuristic Terminator type of robot, but it could be as simple as an iPad with a very high definition type of camera with good speaker system on it that pulls the data in sufficiently that you get a visual of what's going on. Now you've got a visual of the patient, which has been the biggest black box of all our conversations. And then you've got the clinician's firsthand account of what's going on, and you've got the data. As a clinician on one side, you're more able to provide, I would suggest, probably more helpful advice to the clinician who's on the other side, who's not wanting necessarily to transfer the patient, but is looking for some reassurance that they're on the right track and they can do certain other things that are within their facility and their scope before they have to think about sending a patient. So I really do think that this is a capability of that's real potential. We've also got at TOH, we support a lot of communities that are fly-in. They have to send their patients to us by plane. I think about our colleagues up in Nunavut, and that's a huge challenge where, distance, time, and costs are added, plus you're isolating patients away from their families and supports. I think this is simple. This is straightforward. The technology exists. We're already connected with a number of hospitals in the region. Perhaps that should grow and should be expanded as resources allow. And it opens up some possibility. Now, all of a sudden, I think about Jonathan in his clinic, and he's got a patient that he wants to potentially run by a rheumatologist. There's no reason why this couldn't be done with this technology. So I think that's where we're going. We're limited by what we think are our constraints. I think there are some relatively inexpensive workarounds that we can use to harness the existing system. Probably won't be sexy and won't be as glorious as you would see in American hospitals, but I'll still get the same result, which is I got a visual of the patient, I got all the data, and I can communicate with the patient and the provider.
Cool. Jonathan, you had a comment to that? And
yeah,
perhaps
I'm visualizing Jerry's robot coming into the room, and I sometimes, there's the whole glass half full sort of argument. Sometimes people say, well, it's not the same seeing your doctor on the screen as having you there in the room. And sometimes I flip that and say, you know what, exactly. It's not the same. But when I compare to a couple of weeks ago when I was on the inpatient unit and I'm walking into an elderly patient's room with my face half covered, my voice slightly muffled by the mask, the patient can't hear me very well, but I don't want to get that close to them right now, to be honest. And then I think, why not get my $50 webcam and my $50 headset and put it on the patient so now they really can hear me and they can see my whole face on a decent screen. And I'll turn your argument back on you. It's not the same as having me in the room. No, it's way better because now they can see me and they can hear me.
Yeah, point well taken, Jared.
Yeah, and I think the other piece to it is that in this day and age, especially with restrictions on families being able to come in and limitations on families wanting to come in, that's another side to it. There's no reason why you couldn't engage a family in that same sort of conversation. Right now, I'm talking to Sunil and Jonathan on the screen, but I also know that there are other people that are on the call and listening in on the conversation. And so you imagine how powerful that patient experience piece is. Yeah, it's once again, it's not as great as it was before, but it's far better than what we're doing right now because we're flipping it on its head. I agree with Jonathan.
And I had a really positive experience, a family meeting with a patient who we transitioned to end of life care. Family member in Toronto, family member locally, and a family member in Ottawa, all on a Zoom call. We had that conversation that afternoon. Now, even pre-COVID, I couldn't bring that family together, or we might all be on a telephone, with speaker, or they all have to sort of come into the hospital and the next day or two, which may be too late. But actually using the technology that's kind of been forced upon us because of COVID and the restrictions of travel because of COVID, actually that family meeting was a much better experience because they could all stay home. We were on a Zoom call. It was great sort of clarity of the conversation, and we were able to sort of have that end of life care, palliative care discussion with the family, which just wouldn't have been possible without some very simple technology.
Great. Dr. Campbell, I see your question there, and I'll come to it in a second. I wanted to see what you guys thought. We just came from our acute inpatient medicine meeting, or regional meeting, and one of the things that we're talking about was bed occupancy and patient flow. How did you guys see how we could use virtual care or virtual care technologies to improve our ALC numbers, perhaps our post-surgical patients, et cetera, et cetera? Do you see a scope for that to create space in the hospital or to improve flows amongst for our patients?
Yeah, I mean, I'll just sort of comment a bit on, what we've learned with VTAC is that one of the biggest challenges to flows is that is the blocks to discharge, or the barriers to discharge. And so, I'm a primary care doctor. I'm a family physician at heart. I'm passionate about everybody having access to a named family physician. And I think, when I work in the hospital, I know if I'm looking after a patient that has a family physician who I know, I have a completely different level of comfort about discharging people with some issues that perhaps aren't completely resolved, or maybe secondary issues that aren't fully resolved. I have a different level of comfort when I have a patient who has a family physician I know and a patient who's an orphan patient with no family physician. So if we are able through new technologies, or it's not even new technologies, a new model of care to enhance that access to primary care, to reduce the sort of fear of hospital physicians of discharging somebody that day or too early, then you improve hospital flows, you reduce admission times or length of stay times, and so that oils the whole system. So it may not, off the top of my head, I can't think of something of a direct implication to an ALC patient, but if I'm keeping the hospital flow going more smoothly, I think that's where we start to see the benefits.
That's a great point. I agree with what Jonathan's just been talking about with regards to the discharging of patients and sort of trying to get, because I was just on service recently, and that's exactly, I had a couple of patients that I just held on for an extra day or two because they didn't have the network that would support them, that family physician primary care network. And that's what you needed to do. With regards to the ALC kind of question, I think it goes back to a phrase that Jonathan said, which is we have to have a different model of care. And we may have to think differently of what is required or what do we need to do moving ahead. And maybe that this is our opportunity. So when we think about it, ALC patients, right now they're in acute care hospitals, which prevents other patients from coming in. They're not going to be necessarily going back to their home. They're looking for an alternative location. Does that location have to be at the Ottawa Hospital or Arn Prior Hospital or one of our hospitals in the region? I kind of joke it's probably cheaper to put them up at the fanciest room at the Westin Hotel per night and give them free room service and other services at the hotel compared to what we put in per night. But I think the issue is that we need to figure, can we use some of this technology? Can we use some of the resources that we're talking about this evening to try and create still a safe sort of bubble to keep an eye on these patients? Because that's part of the reason why they are ALC, and that's part of the reason why they're not going home, is that there's a fragility to them. And so using the technology to keep an eye on patients through monitors or through wearable devices, but also having a slightly different model of who's looking after these patients. Does it once again have to be hospitals in a hospital setting, or can it be in another type of setting where you've got other members of the healthcare team that are providing oversight and support with support from physicians and others to be there as backup? I think that's part of it.
Yeah, I fully support what you're saying there, Jerry. That for me, the integration with community paramedics has been key to our success. So it's that, like you say, it's that thinking differently about who can also help and provide care here, and that concept of having some non-physician and another sort of person provide initial assessment or initial review or monitoring, and then having the system in place where they can step up to a physician. And in VTAC's case, we'll have a community paramedic see the patient at home, or we have the paramedicine desk where somebody is monitoring the remote board for the patients that have remote monitoring at home. But then they have quick access. They can call an acute care physician, an emerge doc, or they can call a family physician through the VTAC line 7 days a week, and they can do it quickly, and they can work a management plan out. So you take those two components. Doesn't always have to be the highest qualified physician providing all aspects of the care. In fact, it rarely has to be the highest qualified physician providing all aspects of care. So you push it down to the appropriate level, but then the second component is you can quickly link back up the chain of experience and skill if you need to.
What I'm hearing from both you guys is kind of the way that healthcare is supposed to go in Ontario with the development of these OHTs and the regionalization of some of our care. And I'm hearing maybe there's a few obstacles that we need to overcome. And I'd like to get your perspective on it, on how to fully integrate our system. So, Declan has talked about how do we break down that silo so we have a more of a regional approach. Dr. Campbell's talking about remuneration for these peaches for this, which is only supposed to go until spring of next year if you're using the telephone codes and whatnot. What are your guys' take on what are some of the silos that we have existing, and how do we overcome those silos to get to this integrated care? And maybe what your perspective is on how OHTs may get us there, if they do. It's a loaded question. Go ahead.
He's pulled the pin out of this one and he's thrown it out to us. It's a great question, Sunil, and I think that's the thing that's been stymieing the healthcare system, not just in Ontario, not just in Ottawa, but sort of nationally, just because of how things are structured. We could say this is a constitutional problem because of how healthcare is devised. But I think the two key points there, or two of the points that you've raised. Remuneration is a big barrier to changing clinician behavior. Because if it's not paying, why would I do it, right? And that's sort of the crass sort of thinking. But there's a practicality to it. Like you do want to put food on your table, right? And a lot of physicians do a lot of things in the healthcare system without any pay. So, especially when there's a radical shift in some settings, ambulatory care really went 95% to 85% to virtual. And if the model is not there to remunerate individuals, it's going to be tough. And that technology needs to be paid for. If you're a primary care physician like Jonathan, that's got to be paid for somehow. And a lot of primary care physicians and clinics are doing it on their own dime. And that's revenue that they don't have anymore. That's one piece. But I think, infrastructure and policies and structures is another piece. And all of this comes back into culture. If the culture is that we don't trust each other, and if we don't want to work with each other, it doesn't matter. We can put the best policies and put all the infrastructure in place. But I think the question is, do we trust each other and want to work with each other and co-create something that is going to be far better than what we can do individually? I think that's the bigger question. That's the elephant in the room. Back in the 5-10 years ago, we didn't have the technology, so we could say, oh, we just can't do it. Before there wasn't remuneration codes, so we can't do it. But in the middle of a pandemic, all of a sudden things flipped very quickly and rapidly because things had to be done. So now the question is, do we want it to be done that way? So I pose that question out there to the group. Is culture actually the bigger barrier to this? Everything else can be around.
Yeah, it's interesting about the comment on culture and do we want it to be done. I talked a little bit about the VFIT project that we're working on. One of the reasons I felt it would work so well in the concept is because we have a family health centre in Renfrew County, which is a salaried physician model. And for primary care, the elephant in the room is absolutely this huge spectrum of models of compensation for physicians with a huge disparity between fee-for-service and capitation models and salaried models. So, what we thought was that because of the salaried model, we could just sort of move into that, and that would make the whole fee code, billing code issue go away. I mean, I was astounded by the resistance at the Ministry of Health for us to do that. I mean, we were essentially told, no, you can't do that. And there are lots of reasons, and the schedule of benefits was written the spirit of that is that you have to be in the physician's office to bill that code. And if you have a capitation model, there's nothing that says you can do that via remote or virtual means. And the K codes are temporary codes. And you sort of feel like, my goodness, do we wade through this treacle for how long, but it's there, that resistance is there. And I don't have the answer to that. You can put forward ideas and you can say, well, if only we were allowed to do this. And I think that to me was the key to VTAC. Nobody stopped the clinicians and the key administrators and the allied health professionals from just getting on with it. There was an allowance to say, you guys know what you need to do. There's some funding to do it. And this needs to happen really quickly. So get on with it. As soon as the sort of or we draw back a little bit and say, well, actually, we want to keep some control of that, and doesn't fit our pre-COVID thinking as to how family physicians should see their patients, you sort of start to have that drawback on, well, how are we going to move forward and keep going and keep this momentum going? Because ultimately, we just want patients and to have better access to healthcare and a more integrated system which functions better for everyone. And ultimately, even if you're a bean counter, if you do that, you save money. You know, even if you don't think about the huge benefit to people's quality of life and their health and their lifespan, you save money by doing that as well, ultimately. But you don't save money tomorrow.
Yes.
You save money 5 years from now or 10 years from now. So I think that is a constant challenge, is that there still is resistance to the idea of changing the way we do things.
Jerry, you have your hand up?
Yeah, I do. And I think partly it's because there's sort of two aspects, and Jonathan just hit upon the sort of this finance piece. And I think part of it is our budgets in even in our hospital, let alone just the healthcare system, is so fragmented that nobody says what's better for the healthcare system, the global budget, as opposed to my budget line item in the grand scheme of things. And if you're simply looking at your own personal line item, the default position is protectionist. You want to protect what you do and how you do it with a few pieces, as opposed to sort of this more global perspective or collaborative perspective. It throws up the opportunity to say, okay, how can we save the system money? A good example would be if we can help. I think about our colleagues up in Nunavut once again, and that's partly because I went up there last fall, and I think I see Elaine Killebuk on the call, so she knows this environment a little bit better than I do. But it's very costly to have a patient brought down on a medevac kind of situation. One medevac flight could possibly pay for the technology and maybe even staffing. Like once you start adding per month how much gets spent, that's a reality, and it's quite exciting. Elaine's just saying she's in Iqaluit right now. Super exciting to see and to hear from you, Elaine. The second sort of element in this goes back to a comment that Dr. Campbell said just at 5:59 there, if you're looking in the chat. What do patients and families actually want right now? We've given them a taste of something and they don't want to go back. They've actually seen, wow, this system could potentially actually work with, this was all sort of thrown together very quickly, but they've actually seen some better care experiences, and they're feeling connected into the system. So I think, yeah, if we said we're rolling things back, this could be a big challenge. And I think, to be honest, if patients and families and the public spoke up as to what do they actually want in the healthcare system with regards to what we're talking about this evening, I suspect that they'll probably be much more supportive of what we're talking about and what we're trying to get towards, rather than going back to pre-pandemic status quo. I think that's one of the biggest things that we need to think is, how do we engage patients early in the conversation on these things to make the system actually patient-centered, right? And I think we talk about it, but then we have to bring them early into the conversation, not just to, not as we say, to put the bow on the present and say, here it is, here's the package. Help them come in early, co-create this and design it. This is the chance. And this might actually get patients care that they're actually wanting and needing in a system that actually is friendlier to healthcare providers and actually more appropriate for 2020 and 2021 as we think about it.
Mm-hmm. Jonathan, you were saying about how many of the patients really appreciated the VTAC system and the community-based triage assessment. I think that's just going right to Jerry's comments there.
Yeah, absolutely. I mean, it's almost a bit of a standing joke now with the VTAC physicians. You know, that the final comment from pretty much every patient is, "And can you take me on as a patient?" You know, it's, you know, can we keep doing this? And but on a serious point, it's generated huge political support. So our local political leaders, you know, are in tune to this. People are calling them and saying, "This system is fantastic. Don't you dare let this go." You know, for 10 years, I've not had access to a family doctor. Every time my kid has a sore ear or my granny has a urine infection, we go and sit in the emergency department for 6 hours. Now I stay home, I call, and the problem gets solved. So, you know, from the warden of Renfrew County down, and from them across, you know, the mayors across to our MPP and our provincial sort of politicians, they are onto this, you know, and they're doing that because of the feedback they're getting from the community and from their constituents. So I agree with Jerry. This is not going away. People are not going to let this go. No one's going to just say, "Oh well, come March, that's that. Wasn't that nice?" That's just not going to happen. They will be up in arms if this gets pulled. And I'm very conscious that VTAC is an Ontario assessment centre. So we've done all of these extra layers, but all of our funding is as a COVID-19 assessment centre. Our physicians are paid because they can bill the hourly sessional fee code in an assessment centre. The receptionists and the paramedics are paid because we got a budget as a COVID-19 assessment centre. Well, as we speak, there's lots of provincial committees and discussion about who's paying for assessment centres and COVID-19 testing. That gets pulled, VTAC disappears. You know, in 5 months, we've had over 10,000 physician assessments. So, you know, please don't tell me there's no need for this. You know, it's but if they say, well, you know, as of October 1st, there's no assessment centre anymore. You want COVID testing in Renfrew County, you drive to Brewer. Yeah. You know that, and I'm sure that's not going to happen. But you know, if it did, that's it. The whole sort of rug would be pulled from underneath us.
It's interesting because you know, one of the comments, I've been at different health conferences and over the years, and one of the things that is often lamented is that Canada is like the land of pilot studies and projects, right? Great things that sort of get done locally in a small, whether it's a unit or department or hospital or region, and never gets perpetuated anywhere else. The lessons learned never get moved out and expanded upon. And so it's just this whole bunch of stuff. And I think it goes to a comment that Declan's just made, which is there's nobody that's willing to sort of take the research or the project idea and say, okay, we just need to hardwire this into the system. Like this needs to be part of the system, or maybe replace the system. Like, let's be radical about this. Not in the sort of revolutionary kind of way, but in the sense of we have to be open to thinking outside the box. The pandemic has forced all of us to do that. And the last thing we should be doing is going back and saying, I like being in the box.
Yeah,
and being content with that.
I think, Jerry, that's a need to recognize that the system was broken.
Mm-hmm.
So if you have 25% of your population do not have access to primary care, your primary care system is broken. And if you can't recognize that, then people at the Ministry of Health say to people like me, keep justifying your idea. You've not justified your new idea strongly enough to make me change the system. I would flip it and say your system is broken. You know, you justify to me why I shouldn't be doing it differently, and why I should be doing it in the same old way that fails a quarter of the population where I live. And many, many more of that population have a disparity, whether it's a fee-for-service doc who's single-handedly trying to look after 3,000-4,000 patients, or a doc who has a capitation model or a salary and can comfortably look after a modest-sized practice and do it really well. That system's broken. If you can't recognise that, you're always going to pull people back who are saying this is a way we could do it differently. I love that. I've seen that pitch, Derek. Declan's got some awesome pictures. I have seen that one before, and yeah, it sums it up nicely. It's resistance to change, and that's a recognised factor, and we have to sort of overcome that together. Go fast, go alone, go far, go together, and I think it ultimately does come back to recognising that the system was not working well before COVID. Let's keep the momentum to the changes to create a better system.
In fact, actually, the pandemic just unearthed all the problems that were pre-existing. These are not new problems, right? As you're saying, Jonathan, these are pre-existing problems of silos and barriers and challenges and funding and staffing and all those other things. And then the pandemic just tore the Band-Aid off pretty radically.
Completely agree with you. That's the one benefit of the pandemic, and I hate to use it in that term because of so much tragedy that happened, but that it did actually tear the Band-Aid off, and we've seen the gaps in our system in so many ways. And now that we've recognized those gaps, at least the people around this table have recognized this gap and see the value of technology in helping address some of those concerns, what are some of the first and practical steps that you think that we could take at our own individual institutions to make those next steps towards harnessing technology to improve our patient care?
I think for me, the fact is Epic has been bought, it's installed, all those features already exist, means that really the barrier to me using it is me. Right? Those tabs already exist for virtual routing, virtual care, consults, all these things. It's helping my team think differently. It's helping set things up so that our team can function differently, helping our interprofessional staff, our CCLs, our managers all realize that we can round differently and we can potentially get more effective and have more frequent touch points in the day than the magical 2 o'clock bullet round that we do on a daily basis, but Monday to Friday, and not on holidays, right? I think we can do a lot of things within our control already. If we want to push it to version 2.0 or what we can do, it may take a bit more of an investment, but I would say we can already demonstrate positive effects of what we're doing. Jonathan's project with VTAC is already, I would say that's 1.0. It's already showing huge benefits and definitely highlighting a big need. The question is, how do you want to further iterate it? And how do we work with people who are experts in program evaluation to help us get the numbers and figures that will speak magically to the people who make decisions on system reallocation and system resources? I think that's going to be the magical point. The coalition of the willing needs to include people who know how to do good program evaluation.
Jonathan, what do you think next steps should be for people around the table to try and move us in this direction?
I think it's a what rather than a how. So I think we have to continue the momentum. How do you continue the momentum is perhaps a trickier question. A year ago, I've been on prior 6 years now. A year ago, I wouldn't have been able to point to Deep River and Barry's Bay on a map. Now I have half the physicians on speed dial there, and I think that ability to sort of create these networks, and we have a much larger primary care community of practice now in Renfrew County, and we meet regularly with physicians and primary care administrators from across the county. So we have taken those first steps. I think the answer to your question, Sunil, is really let's keep the momentum going. How we do that is the ultimate question, really, and is the ultimate prize, because if we do keep the momentum going, we can create great things, and we've seen how we've done that over the last 6 months. I think we just have to have enough people that recognize that the system has to change. There's no going back, and let's keep this momentum going forward.
That's great. Well, Jared, did you have something you wanted to add there? You look like you wanted to say something. Oh, I think you're on mute.
There we go. Sorry, I was just actually typing away. It was, as we were talking about it, I think the other thing that I was really, I think keeping this kind of conversation going to actually find like-minded people who are interested in actually saying, we've had lived experience with this. We think this needs to be, entrenched, grow, developed, expanded. I think that will be a really practical thing that we need to try and further, and I think push the conversation, right? And so this time we're talking about sort of the what. What is this? Is this even possible? Is this totally sci-fi, or is this achievable even right now? And I think we've demonstrated even in the conversation that it is possible. So then the question is, okay, how can we help this penetrate and integrate into other settings? Where else is going to adopt the VTAC model? Maybe somebody on the east side of this region might be interested in hearing about this. And how does Jonathan share those experiences with colleagues out in eastern Ontario and in sort of the Hawkesburys and places like Cornwall? Well, I guess is they're having the same challenges too with primary care. How do we do this? Well, keep these conversations going, keep the loops going, but then I think we need to find practical steps. Like, we may need to actually say, who's willing to work on this, and what specifically are we going to work on, and start pushing forward and find our partners at other levels. There are champions. I don't have to go and talk to our CIO about the value of Epic because he sold on it, like he's installed it, right? I don't have to convince him and our organization. But the question is, how do we use it differently? How do we use it better? And how do we expand it further?
That's great. Well, on that note, I want to thank you both for a very illuminating and enlightening conversation today. There's so much to unpack and to take home. Did any of you have any other final comments for the group? Oh, my fave picture of complex change. Oh, that's Declan. Declan, you have amazing photographs that are coming in. But yes, I want to thank both of you for it's very stimulating conversation and some practical applications of technology that are outside the traditional consultant to patient that we are all sort of aware of, a bit novel ways to use it to improve care in our community, and some great guidance about what the next steps would be for each of us around the table and to continue that conversation. On that note, we are going to have more conversations about virtual care and different aspects of it coming forward in the next couple of months. And this conversation itself is being recorded, as you may or may not know, and will be available for downloading and viewing at your own time, and then we can share it with the broader group. So thank you again, Jerry and Jonathan, and thank you very much to all the audience for taking time out on a Thursday evening to join us today.
Thanks very much, Sunil. Thanks, Jonathan. Take care,
Thanks,
everyone.
Thank you.